So thank you very much for coming to this talk, and the overall goal of this presentation is to help you make sense of how a university research department can impact the health of our population. So what I want to do is to explain to you the unique role of clinician-scientists in this process, and to tell you how a new initiative from the University of York and Hull York Medical School, the Centre for Blood Research, is going to help tackle blood cancers. In 2023, the UK House of Lords Science and Technology Committee reported an alarming decline in the number of clinician scientists in the UK and highlighted the attendant risks of this to the long-term health and wealth of the country. I want to tell you something about what I do as a clinician scientist and how I do it in order for you to understand why this is an important issue. So, I feel that personal stories are often a good way to introduce complex issues. So this is why the sorts of talks that we have here are so important. So I want to start by introducing myself. So I was born to a single mother in a mother and baby home in Halifax, Yorkshire, so I am actually a Yorkshire person, and was raised by working class adoptive parents who had little formal education on a council estate in Rochdale, Lancashire. So I already had a foot in both camps from very early on. And it was by a stroke of luck that I got educated. My adoptive parents strongly believed in education, and when the headmaster of my primary school refused to support my grammar school aspirations, my mother persuaded the deputy head to give me extra lessons for free so that I could gain the sort of polish more traditionally associated with grammar school's children. So this was incredibly embarrassing for me, as you can imagine, but also very effective, as I gained a scholarship to the grammar school and began the process that would lead me out of my background. I attended UCL Medical School free of charge. It's important to remember that, because becoming a doctor for free gave me a lifelong commitment to the NHS. I received my initial scientific training in Cambridge, undertaking a PhD funded by Blood Cancer UK towards the end of my junior doctor training. And it's also an important point to remember that a lot of these initiatives to give extra training are not funded by the government, but are often funded by the third sector. But this was the start of my career as a clinician scientist. So of interest, the title of doctor, as given to students graduating from UK medical schools, is actually a courtesy title, as medical studies in the UK lead to an undergraduate but not a doctoral degree. So many years ago, when I first qualified as a doctor and my bank card proudly read Dr. A. Fielding, a lady taking payment asked me, did I get that for being a doctor or for being clever? So this lady's comment reflected the genuine lack of scientific depth in clinical training. Medicine is not a science, although current medical practices are often hopefully based on science, but medicine is a skill, an art, and the practice of a profession. But clinician scientists are doctors and scientists. They typically, I haven't even thought about advancing the slides. There we go. Yeah, they typically focus on one clinical area and understand the full depth and breadth of that area, clinically and scientifically, meaning that they can translate metaphorically and sometimes also literally. So translational research is defined as translating results from basic research into outcomes that can directly benefit humans. But scientists and doctors have vastly different vocabularies, and sometimes literal translation is required. You also need to know, if you don't already, that clinician scientists are academics. They're university employees, but who also see patients. And their time and skills often come free of charge to the NHS. So the overall goal of my own research is to understand why children, but not adults, are routinely cured of a disease called acute lymphoblastic leukemia, and to change that. This is an image of what someone's bone marrow cells look like when infiltrated by leukemia. And this is an image of normal bone marrow with the many different cell types. But what I need to be able to do my job properly is to work where I can do and be surrounded by excellent basic science, to generate the ideas to test in the clinic, to be able to do clinical trials. I need to have access to population level or epidemiological data. And last but not least, to still be able to care directly for patients. Seeing patients personally remains incredibly important because it allows me to see exactly how the diseases and their treatments affect people. And the personal stories that I hear from patients help me to work out what the most important scientific questions are that I should try to help answer. And patients help me to design the best clinical trials that I can. Seeing patients also gives me the opportunity to get properly worked up when our health service is not offering the best care possible. And I do spend a lot of my time being properly worked up. I'm fortunate that a lot of my work has an international dimension. So I'm very familiar what is available for patients in other countries and frequently interact with and cooperate with doctors and scientists from outside the UK. I used to rarely be embarrassed by being British, and I used to be able to tell my patients that they would not get better treatment if they were in France or Germany or the US, because that is a very common question. At present, unfortunately, I can no longer say that with certainty, and there are multiple reasons for this, which I'll be happy to discuss. Talking basic science, clinical trials, population level evidence, and direct patient care. Just bear that in mind about the Centre for Blood Research in York. So now I'm going to turn to talk to you about what actually is a clinical trial, because I think there are some widespread misconceptions. So a clinical trial is any medical research involving people. Clinical trials can be observational, without testing any interventions, and may involve registries, epidemiological or cohort studies, and can allow researchers to collect samples from patients in an appropriately safe and regulated manner. As you're more familiar with, more likely, trials can also test an intervention. This does not need to be a drug, it can be a device, or even something like an exercise regimen. There is a necessary period of non-human laboratory testing before permission or even the desire to move into humans is granted. But subsequently, phase 1 studies usually establish the basic elements of safety and define if it's a drug, the correct dose to be used, and so forth. And they often involve fewer than 20 subjects. Phase 2 trials begin to seek evidence of efficacy. And it is only when an intervention looks like it might be effective that randomized trials take place, comparing a new treatment or approach against the standard of care or even against placebo in situations where there is no existing effective treatment. It is generally at the conclusion of phase 3 trials that interventions are approved for human use. But it is important that, even after approval, interventions continue to be studied, widening the population receiving them compared to the highly selected populations that are included in trials does tend to reveal important new data. So what do you need to do to carry out a clinical trial? And where do clinician-scientists fit into this process? Of course, you need a drug or an intervention that you strongly believe is worth testing. And it's a lot of work to do a trial, so you need to be very convinced that it's worth doing. Sometimes clinician-scientists generate the interventions or work with scientists to do so. So a sponsor is legally responsible for the conduct of the trial, and it can be up to the clinician-scientist sometimes to persuade their university to sponsor the trial if that's what's known as an academically initiated trial. Of course, large pharmaceutical companies also sponsor trials, and it is very common for academics to work together with pharma on these sorts of trial collaborations. There has to be a chief investigator who is a clinician, not always, but usually a doctor. It could be a nurse or a physiotherapist or some other clinically qualified individual. And that person is the overall research leader for the project. The chief investigator works together with the sponsor to gain the appropriate approvals, including ethics and regulatory approvals, and works to identify sites, in my case, NHS hospitals, where the trial will be conducted. And obviously to develop relationships with these sites so that you can help the sites as best you can. This process costs a lot of money, takes a lot of time, and is subject to myriad rules and generates a huge amount of legally mandatory paperwork. Clinician scientists often add value to such trials by designing correlative science studies, ensuring that specimens are collected that can be tested alongside the clinical data. An example would be to determine which genetic subtypes of a disease might benefit most from the intervention. So this is a summary of the whole process by which new medicines become available for patients. The first bit, the bit that takes 10 plus years, we've just discussed. Following this, the regulatory body scrutinises the evidence in great detail. In the UK, that's the MHRA. You'll probably also have heard of the European Medicines Association, of which we used to be a member, and the FDA in the United States. The regulatory body decides whether to grant a licence or a marketing authorisation. So for this to happen, the medicine or the intervention must be effective, but also appropriately safe in the circumstances. In the UK, we have a further step, NICE, the National Institute for Health and Care Excellence, which performs a further step looking at the data and the outcomes from the trial to check value for money before deciding whether the intervention should be available and paid for by the NHS. You will recall that the overall goal of my talk was to help you make sense of how a university research department can impact the health of our population. So I wanted to show you what we're developing here at the University of York and the whole York Medical School in the newly launched Centre for Blood Research. As a clinician-scientist, I've joined the amazing existing talent in epidemiology and basic science here at York in order to help start the process of translating science, which is carried out locally. It would not be me if I didn't want to make some overarching points before concluding. I want to tell you why it is particularly important that this sort of initiative is happening here in York and the whole York Medical School. First, I need to tell you about health inequalities, which are unfair and avoidable differences in health across the population and between different groups within society. Whilst York itself is among the 5 least deprived boroughs in the UK, some of the neighbouring regions, for example in the Humber Estuary, are among the 5 most deprived boroughs in the UK. Whatever your politics, it's pretty clear that a healthy population is a benefit for everyone. If you're an overlord and you need lots of workers, it would be better if they were healthy. It's an important point, and one that goes overlooked, that healthcare spending is directly correlated with the health of a nation, regardless of the healthcare system being used. The United States is the one exception where spending is vast, but some people have incredibly poor health and no access to healthcare. The NHS itself is a reasonable healthcare system, but it is vastly underfunded and has a huge shortage of doctors, nurses, and other professionals. In specific geographical regions in the UK, there are many unfilled GP and consultant posts. This is just one of the many contributors to health inequalities, but the reason I mention it is that it's what the new medical schools were designed to address and is part of the reason that I'm here in York. Considerable evidence suggests that doctors often stay and work in the regions where they're trained. The new medical schools are sited in regions where the NHS most usually struggle to recruit doctors. It's vital that doctors trained here have the same opportunities to learn about science and do PhDs and become clinician scientists without having to leave the area, something I call bloom where you are planted. So just to remind you that we're committed to working together in York and the whole York Medical School to learn about the science of blood cancers, develop and test new treatments and outcomes for patients. Science is conducted by teams and someone has to pay for the work. I'm very grateful to my funders, particularly Blood Cancer UK, who funded my PhD and a 5-year fellowship for me when I returned from the UK, and to the other funders listed here. A research lab at the centre of what I do, but I work with a variety of very talented people, by no means all of whom are listed here. And last but not least, I want to thank and acknowledge my new colleagues here in York. With already, I have developed some amazing collaborative relationships. Ian Hitchcock, the director of the Centre for Blood Research, who's pictured there in the middle. I would also like to thank Dimitris Lagos, David Kent, Bill Gray, Catherine Bridge, Eve Roman, Alex Smith, Deborah Howells, and I would like to thank you for listening to my talk.